Hello, I'm Andrew Herring with CA Bridge, here to provide a quick overview of our guide for helping people struggling with methamphetamine use. I'm an emergency physician and addiction specialist, and I use this guide every single day I'm on shift. Methamphetamine is both very cheap and very strong. It is performance enhancing, it can be incredibly pleasurable, and it's no surprise that it is very popular everywhere from nightclubs to fighter pilots. While undoubtedly it has some positive impacts and effects, if you're an emergency physician out there or a clinician of any kind in the emergency department, you know that the burden of suffering from people who have gotten too deep with their methamphetamine use is just enormous. And there's a lot of people that are really struggling and want and need our help. You can find this guide at bridgetotreatment.org and search for methamphetamine. Well, our big message is that you can help people struggling with methamphetamine use at every stage of use. We're going to start with crisis management. So the neuropsychiatric crisis occurs after you've been using, you increase your use, you start to binge, and binge means you're using and you're not sleeping. We're going to repeat that. Binge means you're using methamphetamine and not sleeping. Those two things go together. So people typically will have no sleep for 3, 4, 5, 6, 7, even 2 weeks or more. That is actually what people report. That's when people come in crisis. They're confused, they're delirious, they're toxic. So this idea of neuropsychiatric toxicity, their brain functioning is literally compromised. Then they go into that crash, that intense withdrawal state where they're just profoundly exhausted, and they wake up depressed, incredibly hungry, so-called hyperphagia. They just eat and eat and eat because they have not eaten or slept in days. This is all predictable. And our goal is to try to help them not return to use, to prevent that cycle of methamphetamine crisis. So to get this started, when you're seeing someone who's having an acute neuropsychiatric crisis, you're an emergency clinician, you know how to calm people down. Just lean in on that. Use whatever tools that you're comfortable with, benzodiazepines, antipsychotics, or ketamine to help settle people down. Then the next thing is to understand that sleep is essential to recovery. So you really don't want to be discharging these patients as quickly as possible. You want them to rest. Because think about it, if you're just discharging them out into the street, there's a high chance that some negative consequence is going to occur, either to them or to someone in the public. So it is a public good and a good for that person to let them sleep. So support them through this washout phase, and when they wake up, let them eat. Let them have double portions. It's not a malingering or an inappropriate thing. They are technically ravenous. So it is a medical necessity to refeed. When you've gotten them to the point where you can talk with them, start engaging so that you can promote this concept of self-treatment of MA-induced psychotic features, anxiety, and insomnia. You don't need to talk about schizophrenia. You don't need to use those loaded terms. It's really about saying like, hey, here's a tool that can slow your thoughts down, that can help you go to sleep. And if someone is talking to you about seeing, shadows move or feeling like people are creeping up on them or hearing voices, there you can directly tell them like, this is a medication that you can keep on hand and take as needed to help quiet those down and make them less distracting, to enable you to think more clearly and to sleep. Once people have resolved their initial crisis moment, mirtazapine is a fantastic medication that can be used to help with the withdrawal. It helps with some of the restlessness that you probably have seen with people who are in the crash phase of methamphetamine use. It's also a rapid-acting antidepressant. It's very safe. Finally, it improves sleep. So just getting them started out of the ER with 30 milligrams of mirtazapine is a nice way to get started. It's concrete. It's a gift that you can give them. Everything to do with methamphetamine use disorder patients, you need to wrap with as much health promotion and harm reduction as possible. The injecting methamphetamine is incredibly dangerous and harmful. So if they're injecting, getting them to smoke. If they're smoke, getting them to step down and have longer episodes of abstinence. Leaning into whether or not they're having high risk condomless sex. Or any other risk factor for contracting hepatitis, HIV, syphilis, or other STIs, and providing emergency contraception. And we have separate guides for all of those things. So I really encourage you to lean in on identifying acute HIV and treating it, screening for hepatitis C and syphilis and treating it, as well as offering PEP and PrEP. The discharge bundle for someone that you should try to do is give them shelter, food, support, clothing. Naloxone is just a great thing, a universal precaution everyone should have if they need them. Offer them safe sex supplies. Ask them about mental health treatment. Encourage your partners to implement what is called contingency management programs that recruit people out of your emergency department. This is a very concrete thing of just providing incentives to people to take a break from methamphetamine use. It's very, very structural, very concrete, and it has strong evidence behind it. Linking people with primary care to treat the downstream effects of exposure to methamphetamine, particularly the cardiovascular risks of stroke, heart attack, dissections, is incredibly important. So there's a lot they can do, lowering their cholesterol, lowering their hypertension, and of course, if they're already progressing to heart failure, that's a must to get them tied into care. The prescribe and dispense bundle is olanzapine 5 milligrams that's taken as needed by mouth every 6 hours. Give them 30 tablets. Let them know you want to limit it to 20 milligrams a day, but encourage people to use this as a way to chill out, to reduce the intensity of their sort of racing thoughts and any kind of psychosis spectrum thinking. Support them to sleep well and have fewer cravings by initiating mirtazapine of 30 milligrams PO at night. Give them 30 tabs. Now, the next step is to consider bupropion, and that would be for the morning time to help people wake up and have more motivation and improved mood when they are stopping use of methamphetamine. And that's something we can dig into a little bit later in more detail. That wraps up the basic approach to methamphetamine crisis in the emergency department. Please see the link underneath the video so that you can access the full guide. Thank you.